This conference will now be recorded.
And I want to welcome everybody to the Tuesday, the February 25th session of the high-risk recurrent and advanced prostate cancer virtual support group. Let's see, I'm going to do a roll call off the top. And these are the people that I see that are participating right now. So Jake, John Appler, Dennis Correa, Joe Blanchette, Len Sierra, Dennis McGuire, Les Shelderup, Russ Smith, and Jerry Pelfrey. Did I miss anybody?
Hey, Russ, we're getting feedback.
I already muted him.
Oh, okay, thank you.
If you need to talk, Russ, raise your finger, okay, or your hand.
So that system of Russ's is giving him a lot of grief. I don't know why, but something's picking you up. Oh, he just stepped away. I wonder if it's, you know, we find this problem quite often with people that are using iPads and Mac. Are you using an iPad or a Mac, or using
I'm using a ThinkPad.
ThinkPad, okay.
Do you still have, can you hear the feedback now?
Can we hear the feedback now?
It's a Dell.
It's a little bit better.
It's a little bit better.
Yeah,
okay.
I'm not getting it.
Okay. And someone else has just come in on the telephone. Who might that be?
It's Jay Mills.
Hello, Jay.
Hello.
Hey, Jay.
Hey.
Okay, so since we don't have any new faces, and a lot of old faces, hopefully we'll have plenty of time for everybody. And so we'll start right at the top and see who would like some time today. Jake, would you like any time today, senor?
Yeah, I do want to ask people if there anybody else is having issues with our videos, and I also got a blood test, which is not good. So.
Okay, great. Well, not great, but okay, yes, absolutely. John Appler, would you like any time today?
Yeah, Rick, thanks for asking. My condition is pretty stable, but I am curious about because we're all in this high risk category for coronavirus, I'm curious about anything prophylactic the human's doing to, try and, ward it off or remain strong against it. So any thoughts about that would be helpful.
Okay. Dennis Correa, would you like some time today? Sorry.
No, Rick, I just got to listen in.
Okay. Joe Blanchette, would you like some time today?
Yes, a few minutes.
You got it. Len, would you like some time?
No, thank you, Rick.
Okay. Dennis McGuire, how about you?
Yes, I have an update, Rick.
Okay, super. Les Shelderup, anything for you today?
Today, thank you.
Okay. Russ, anything you'd like to talk to us about today?
Maybe 2 or 3 minutes. That'll just be it.
Okay. Jerry Pelfrey, anything you'd like to speak about?
No, thank you, Rick.
Okay. And Jay Mills, anything you'd like to talk about today?
No, nothing today, thanks.
Okay. Well, maybe we'll even have a quick meeting. That would be something. And somebody just arrived. We don't know who they are just yet. I'm just wondering whether we should wait to see if they could possibly be somebody new. let's see, as they, oh, it's Sylvester. Sylvester's not new. Hello, Sylvester.
Hello, everybody. Sorry I'm late.
No worries. Would you like any time for anything today, Sylvester?
No, thank you very much.
Okay. All right. So let's kick off with Jake, both with a general issue and with his own issue, whichever you want to start with, Mr. Hannum. You're muted. You're muted. You have to start again.
It always helps to turn a mic on.
It's
Russ, I'm
But you
going
have to mute. You have to mute Russ.
Yeah.
I have.
Okay.
I have.
First of all, I have a question with anybody having access to or anybody that accesses our YouTube videos that I make. You know, I go, hi, this is Jake, blah, blah, blah. And then I put a little click here button and you click on it and then you go to, theoretically, you go to the GoToMeeting site and you can view the video. Has anyone had a problem with that in the last couple of days?
This is Jay Mills. I never have been able to make that work. I just have to search through my subscription to ANCAN, and there only shows about maybe 5 sessions, and it doesn't go back any further historically. The button never has worked for me. I can't click on the button.
Do you use it from a from an iPhone or a smartphone?
It may be from the smartphone. Yeah, I've had that trouble. It may have been from the smartphone.
Okay, well, what you need to do is go to if it's a smartphone, go to, if it's an iPhone, go to Apple, the Apple site, and if you have an Android, go to Google Play, and you can upload or you can download the latest version of the YouTube app. That might solve that problem.
Okay, very good. Thank you.
And just to address the other problem, Jay, when you go to the YouTube site, there is an option on there to view all the videos, and so if what you're seeing isn't on there, if you're only seeing the last 4 or 5, you have to click. I think no, it's not play all. Hold on a minute. It's oh, sorry. I had the screen up and I just tried to. I just pressed the wrong button and it started playing.
I'll look for that. If it's there, I'll look for it. I didn't know I needed to look for that. Okay, thank you.
It'll show videos. Is it playlists that shows them all? No, it's not. Videos, maybe it's, yes, videos. If you click on the tab that says videos, you get our whole history, going back as far as you want.
Excellent. I'll find that. Thank you.
Okay.
Hey, by the way, Jake, I just tried to use your link to access the recorded session from Valentine's Day, and it worked fine, no problem.
Okay. But that's probably because you're logged on to GoToMeeting. You logged on as an authorized user of GoToMeeting with your password?
Well, yeah, that's how I'm here, I guess, right?
Well, yeah, well, that's the issue. When I log on with my password, I don't have any issue. But when I sign out, that's when the issue comes up. Is for people who do not have, who are not authorized users of GoToMeeting, are having problems. And of course, we want the video to be available to anyone.
Right.
So that's why I was asking anybody else other than a moderator. Anybody else having an issue?
No, not that we know of.
Okay, well, I guess
Okay.
we do have another caller on the caller 5. Just called. Care to identify?
I think it's Larry Fish.
It's
Go ahead.
probably me. This is Russ. This is Russ. I dialed in, and so you didn't have the background.
Oh, thanks, Russ. Thank
Okay.
you, thank you. Yeah, that works great. So we
Yeah.
can see you and we can hear you fine. Okay, and then I also see that I think Larry Fish has joined us too, so, which is good.
Yeah.
Let me just check. Oh, his microphone isn't on yet. So if his microphone isn't on, we'll wait.
He left. He left again.
Yeah, he's having some issues, I can see. Okay, Jake. So anything else that you wanted to address on the technical side?
Well, right now I don't have a solution. I don't know what I don't understand exactly what the problem is. Go to meeting. I was on the phone with them for an hour, and they were trying to be helpful, and they gave me a bunch of workarounds, but it's a PITA kind of thing, pain in the ass. So hopefully they'll fix it, but if not, just try to bear with us. We apologize if you have an issue with it.
I always thought PITA is what you put falafel in.
The what?
I thought PITA is what you put falafel in.
Oh, yeah, that too.
Falafel and hummus. I'm getting hungry. I'm thinking about it. Okay. All right. Go tell us what's going on with your blood work, please.
Okay. I had my blood work last Wednesday. I've been on apalutamide now for 46 days, but at that time it was about 32 days, and the results were not good. My PSA went from approximately 38 to 47.8, and was really, I don't understand this, and I have not talked to before you ask, I have not talked to my oncologist yet. But what's really weird is when I was on abiraterone, my PSA was less than 3, which was great. This time, since now I've been on this apalutamide, my testosterone jumped to 119, which is crazy. And I just don't understand it. Maybe somebody knows. Does apalutamide suppress testosterone? Obviously, the Lupron is not working anymore for it to jump to that extent.
Len, do you want to go first? Because
Yeah, well, okay, so drugs like apalutamide, darolutamide, enzalutamide, they only block the androgen receptor. They don't have any effect on the production of testosterone. That's why with those drugs, you do need to give an LHRH agonist or antagonist like Firmagon or Lupron or Eligard, whatever. Those are the drugs that stop testosterone production. Obviously, in your case, Lupron seems to no longer be doing that.
Right.
I don't know. Maybe you could try switching to Degarelix, Firmagon. It's not fun, but it probably would keep your T levels down.
Well, that's what I'm
opinion.
But it's just very strange, Len, that it went from less than 3 to 119 in less than a month, or 5 weeks. That's a crazy.
Yeah.
It's almost like I'm not even taking the Lupron anymore.
I'm wrestling because I seem to recall that Paul Korn said something about that to Ken Anderson. Something to do between enzalutamide and the testosterone. And Ken, unfortunately, Ken isn't on the call right now. I thought he was going to be. He may come on a little bit later. If he does, we can definitely ask him.
Okay.
Let me just let me just look at, does anybody else on this call have any clues or thoughts as to any relationship between the androgen receptor drugs like enzalutamide, darolutamide, apalutamide, and testosterone? Okay. Let me see if I wrote something down in my notes on about from Ken and
I mean, I assume that apalutamide, you're supposed to take an LHRH along with it, right? It's not a monotherapy.
correct.
Right. When's the last time you had a Lupron shot?
Well, I got it last week.
Go.
You know, they took the blood, and then I got my Lupron shot right after that. So
When
it
was
had
the
been
last
4
time
months
before that?
4 months.
4 months before it. So you were at the tail end. You were at the tail end of a 4-month shot.
Correct.
I mean, that could. And have you tested again this week to see if it's working?
No, I have not.
Okay. Well, if it were me, I would test it right away and see if it's back down again. Because that's the only way we're going to know if the Lupron is working or not. And it may have been something to do with the tail end of a Lupron shot, where some people do experience issues. You know, usually you have a half-life, but we've heard, or it may have been a bum shot, or, you know, it could have been something really stupid where they thought they were giving you a 120-day shot and they gave you a 90-day shot.
That's a possibility.
You know, it could be something as simple as that. But because the testing was right at the end of the effectiveness of your Lupron,
right?
That's the first and the simpler. You know, keep it simple, stupid.
I mean, it's never been that. You know, I've been getting 4-month shots from the very beginning, and my PSA has never been less than or more than 25. And then on the abiraterone, it was less than 3, like I said. And now suddenly it just skyrocketed, and that's just very, very concerning to me, as you might imagine.
Well,
not to mention the PSA going up.
Well, the PSA has gone up because the testosterone's gone up, and that might have not, you know, so it doesn't really even reflect whether the darolutamide's working.
Apalutamide.
The apalutamide is working, because the apalutamide's, you know, it's engulfed by a larger amount of testosterone. But you know, my feeling would be to check it out, to get some blood tests again, not to wait. Oh, here's Ken Anderson. Terrific.
Hi, Ken.
Hey there. Sorry about that. I got delayed.
That's okay, because you must have heard we were calling your name. Forgive everyone else. Forgive us on the call. Let us just recap for Ken, because we think you may have some information. Jake tested on his apalutamide, having been on it for how long? A couple of months, Jake?
Not even a little bit more than 30 days at the time.
30 days at the time. And his PSA had gone up from 37 to 48, roughly. And the weirder thing is that his testosterone had gone from, what level was it?
It was less than 3 on the abiraterone to 119.
To 119.
And let it go like 5 weeks or so.
But he was tested at the tail end of a Lupron shot. Now, a couple of things. One, and I know you've looked at this quite extensively. You and Cameron have looked at it. Tail end of these LHRH shots is one question, whether that could have been the issue. Another is, didn't Korn say something to you about enzalutamide and testosterone?
Yeah, he did think enzalutamide would lower my T level, but it did not. In fact, when I went on enzalutamide, my testosterone doubled. But it was again at the tail end of my 3-month shot. Jake, was that a 6-month shot or a 3-month shot or a
4 month.
4-month shot? Boy, that's a huge jump. The one thing Paul did do though, because mine increased, he switched me from Lupron to Firmagon, and I haven't gone and I haven't had labs since I switched to the Firmagon shot in the belly. So I'm scheduled for the 5th. Yeah, I don't know. That's a big T level jump. You wouldn't think you're on apalutamide, right?
Yes.
I don't know. I don't know why there'd be such a huge jump. I would do monthly Lupron shots. Are you on Lupron or Firmagon now?
Lupron.
Cam's not a good comparison because he had his nuts cut off. I'm sorry, he had his testes removed. So,
Same thing.
yeah. So
Yeah, but I know that the two of you have done, have really done a lot of looking
I
at.
watch it. He and I both, we watch it real close. It's one of those things. If in fact if the cancer is going to feed on testosterone, you want to do what you can to lower it. Unfortunately, enzalutamide did not lower my testosterone like he thought. There's something within my system, and hopefully abiraterone, which works kind of up higher on the food chain, will actually do something different. I did watch Charles Drake's recent presentation. Well, it was from December 23rd of 2019, the comparison between abiraterone and enzalutamide, how they work differently, substantially differently.
Oh, yeah.
So,
yeah.
have you done abiraterone, Jake?
Pardon me?
Have you done abiraterone?
Yeah, it didn't work. I was on enzalutamide for about 30 months. It worked for a long time, then it stopped. My testosterone never went below 25 on that, or I never went above 25 on Enzy. When I went to abiraterone for 6 months, it went down to less than 3. But my PSA kept going up.
Oh.
So hopefully in your case, the abiraterone will make a difference as far as your testosterone goes. It did for me. But as soon as I got off of it and I went on the apalutamide, it like, as you know, skyrocketed.
Yeah, but I don't know that it was the apalutamide. I mean, when you say as soon as you went on, of course, we don't know, but it might have been coincidental that you changed at the same time.
True.
Because when you actually got tested last time, when this test had happened, how long had you been on the apalutamide? When the blood was drawn?
36, 37 days.
And
more importantly to me, Rick, would be how many milligrams, if you're on Lupron, what was the shot dosage? Do you know?
I assumed it was the right one for 4 months.
I know they make mistakes all the time. I mean, I always ask them when they're giving me the shot, how many milligrams are you giving me?
Right.
So I would check and make sure that in fact what you think was a 4-month shot was a 4-month shot.
Yeah. That was my very first response. If you listen to the recording, you'll hear that. I agree with Ken. I'm wondering if it wasn't just human error here. It should be, I think it's 7 point, Len, correct me, but I think it's 7.5 per month.
It's 22 per 3.
Yeah, it's 21.5 for 3. What's the measure, Len? Is it grams, milligrams?
Milligrams.
Milligrams, I believe. But yeah, it's 22.5 for 3 months, 7.5 per month. So Jake should have gotten 30 milligrams.
Right. I guess I've never heard of anyone getting a 4-month shot.
Yeah,
There's another possibility. Was there anything unusual about the injection, Jake? Because it's supposed to be an intramuscular shot or depot. if somehow they miss the muscle, I imagine that could certainly affect levels.
Well, that's possible. I mean, she always gives it to me in my shoulder. You know, the meaty part of my shoulder.
Right.
Been doing that from day one.
Yeah.
You know, I hear what you guys are saying, but I mean, a 4-month shot, for 2.5 of those 4 months, I was on abiraterone and my testosterone was less than 3. And then suddenly, coincidentally, as Rick said, it was probably coincidental. Once I started the apalutamide, that's when it went up.
Yeah, but it could be an error in the dosing. And the other thing is, and I know we've told you this before, you're the only person I know who gets it in the shoulder. I mean, most everybody else gets it in the top of the hip, the butt, sort of top of the hip. That's where I always got mine, and that's where I know everybody else has gotten them. I've never heard it given in the shoulder other than with you.
Me neither. And I've talked to a bunch of guys. They always get it either they get the Lupron right in the back. I get it right below my belt line in my butt on the left hand side. And then the Lupron, of course, is in the belly. And you're absolutely right. That was a painful 240 milligrams the first shot.
The Firmagon, not the Lupron. The Firmagon is in the belly.
Firmagon. Yeah.
Right. And you know what they used to do with me is, because she would always look, they'd give it one side left, and then the next shot would be right, and then the next shot would be left. And the nurse would always go back and look and see. So she gave it me the opposite side each time.
Yeah, I'd call and ask them what the milligrams were and confirm. I'd go in and get another damn testosterone test here 10 days or 20 days from now and see exactly where it's at again. Could have been a test result problem too. They could have had a problem in the lab.
Possible.
I know. So it's unfortunate, but I do think it's possible, both with the shot an error and the test. So that's a huge jump in a month.
Yeah.
Or that's a 4-month jump though, right?
No.
Because you're getting tested every month?
Every 5 weeks or so.
But I would still make an appointment to go in next week and get your testosterone checked.
Okay.
Yeah, I'm just thinking, that kind of a jump would be something that guys who stop hormone therapy would be happy to see in just 1 month, to go from single digits to 119. They'd be like, yeah.
That would be me.
You don't hear of that. It doesn't seem right.
Something's wrong.
There's something wrong with that for sure. It's not normal. It's not just not.
Yeah,
we know that it's not normal.
Yeah, I mean, testosterone just doesn't come flooding back that quickly. Most of you guys on this call, you wish it did.
Maybe it was an anomaly. Maybe the blood test. Maybe it was a bad blood test. That's very possible too.
Yeah, I would test again, both the PSA and your. The other thing, they could have gotten the results mixed up. Could be someone else's results.
I know.
Well, that's possible.
You hate to think that.
It's got my name on there, but yeah, it's possible. Everything else.
It's highly unlikely it went up that much, Jake. It is in 4 weeks. Unless you're just a man. Yeah, it's highly unlikely.
Let's keep moving. Anybody else want to say anything to Jake on this, or have any thoughts that we haven't covered or we haven't had? Okay. Anything else, Jake?
No, that's it. That's enough.
It is enough. But will you promise us all that you'll get some blood drawn very quickly?
Yeah, I will.
Thank
you. I'm gonna call you tomorrow and see if you have it scheduled. It'll be in the afternoon, so pick up.
You're supposed to call me anyway, aren't you?
I have been. You're not picking up. Your wife's beautiful voice answers the phone, but I never get a call back, so I don't know if you're getting the messages.
No, I'm not getting any messages at all.
I left 2 messages and 1 email. I'll call you tomorrow around 1 o'clock.
Okay.
My time.
When was the last time you called me, Ken?
2 days ago? What day did Rick and I talk?
Yeah,
Rick and I talked maybe on Friday?
No,
I don't know.
we talked yesterday and we talked today on 2 different issues.
So anyway.
All right. There's going to be an inquest in the Hannum household. I can see this right now. I see it coming up. Okay.
Are you by any chance Luomo Creatives?
Who? No, that's not me.
Okay, that's the only thing that I don't recognize. Your name is not on here.
Do you have my cell phone in there? Oh, we can talk about it later, Jake.
Yeah.
Send each other, you can send messages to each other on the private chat window. There you go. All right. John Appler had a very good question. John, would you like to repeat the question?
Sure, Rick. Yeah, I was been following this coronavirus pretty closely. I noticed that everybody on this call is in a high risk group, being that we're typically over 60, we're immune system compromised, and so we're kind of as it will probably cut through the population and not affect a lot of young people, will probably affect a lot of us. And wondering if anybody's read about this and anything that we can do precautionary wise, medication stock up on, anything that we can get our doctors prescribed in advance and keep around. Just curious about anybody's thoughts about this.
Stay off the bloody airplanes.
Yes.
Stay away from
that's a good
crowds.
point.
Yeah, no
Good
cruises,
point.
no airplanes,
Wash your hands frequently.
Yes.
Get
Yep.
all of
They
get all of the immune shots that you can, like vaccines, like the flu. And at least that's
absolutely.
what my doctors told me. Make sure you get all those things, pneumonia, flu shots. They do intend to generally give you a slight boost in your immune system.
Yeah, that's the other thing that my pharmacist said too, was look for immune boosters. Vitamin D is one. I don't know if there's any others that are really effective or that you guys know of that would help on that.
You could wear a mask in public. That might help.
Yeah, right. That's a consideration.
If you're in China, wearing a mask is not unusual, but in the United States, wearing a mask, people would look at you kind of funny. But I mean, that might be one way of minimizing the exposure.
Yeah, good point.
And like Dennis says, make sure you wash your hands frequently, especially when you go out.
Yeah,
I was doing all of this stuff, John, just about 2 weeks ago here, and all of a sudden I woke up with a sore throat, and it just materialized into a sinus thing, and I'm getting close to 2 weeks, and I'm just barely getting over it. But I really thought I was doing all the stuff because I know I could be susceptible. If somebody with colds, I'd stay away, wash my hands half a dozen times a day, all this kind of stuff, and I still got it. So.
Yep, I hear you. No, I've had pneumonia. My boss actually died of pneumonia in his 40s. Very unusual, but I think this one's going to be a little bit harder to catch than the others. Stop because of the being able to carry it around without symptoms for 2 weeks. So I think the stock market's dropped 1,800 points in the last 2 days. So it's going to have a lot of economic impacts too, in terms of factories shutting down and supply lines cut. So I think it's one we should all watch.
The one thing that I get concerned about is the pharmaceutical companies, especially the ones that supply us. Most of their ingredients, especially the key ones, come from China or India. And I don't know about Lupron.
Penicillin and aspirin both apparently are heavily sourced, or at least the ingredients are sourced out of China too.
Yeah, well, we've got no aspirin manufacturer in the U.S.
Amazing.
The last one was Norwich Pharmaceutical up in Norwich, New York.
Len, who was it at PCRI? Was it Moyad that pushed getting all the vaccines you can get?
Mark Moyad, yes. Yeah, get as many vaccines as you can. He thinks they have a general immune boosting effect. I just wanted to add also that let's keep in mind the death rate from infection with coronavirus is 2%. It's not as if you get the coronavirus, you're going to die. I mean, 2% is a lot, I guess, but there's a 98% chance that you won't die from it. If you have a fever, I would go to a physician.
Yeah, good point. Here and how, I guess the issue, the reason to watch it would be the complication rate language. I think they said in our risk categories was about 20 to 30%. I mean, you need actually a hospital room to help you breathe. And here we are in Maui, we probably have, 10 of those rooms on the whole island. So that's the thing, probably is the biggest concern is that complication rate.
If you want to hear more about Moyad and vaccines, search on our website for the Moyad webinar. We did a webinar with Moyad a couple of years ago. It was in conjunction with the guys in Australia and some other people. And on that webinar, he actually talks about his hypothesis about the importance of getting all the vaccines that you can get. And he's also talked about it at PCRI. But if you want to listen, you'll find it in our archives.
Yeah, that's a really good takeaway. I really appreciate that. It makes complete sense about stimulating the immune system. And I'll start following him more too on his posts as well. Thank you.
Yeah. Anyone else want to contribute to mitigants to avoiding getting sick from the coronavirus or similar before we move on? Okay, let's move on to Joel Blanchette.
Yes, I believe the last time I was on with you a couple of weeks back, I had just finished my first treatment of SBRT. And as I told you that back then, 4 hours before I had my first treatment of SBRT, I got a PSA test. I got the results of that about 7-8 days later, and it was 1.26, and that was high for me. It was the one before was 1.02. That was in December. In November, it was 0.09, and in August, it was 0.07. So it's quite a straight up jump, which I already knew. That's why I went to the clinical trial at NIH. So I did 3 treatments. The second treatment was the next day after I talked to you guys, which was on a Wednesday, the 5th of February. And I could feel the radiation going in even more than the first time. It was a little painful. The third time, which was on February 5 on Friday, I was kind of numb. Didn't feel much at all. And so that was the last treatment. The radiation oncologist wants to see me in May with a PSA in hand after 90 days. And so I sent the results of my blood test that I took on the 3rd, 4 hours before the first SBRT treatment, to Dr. Anton Arakis at Johns Hopkins. He says, that's good, but I want to see one every 30 days. I think it'd be very interesting to see what happens to your PSA every 30 days. So I just wrote him back tonight, as a matter of fact, about half an hour ago, saying, I'll do that. I'll take a PSA and send it to you for the next 3 months. So that's where I am, basically. SBRT is done, and we're just awaiting the next PSA test, which he told me to take on 10 March.
Okay.
Yeah.
And no side effects to mention from the SBRT itself, focused on the iliac?
Yeah. The doctor said, the radiation oncologist said it might be, painful for a couple of weeks. I really didn't notice any more pain for the first couple of weeks. Of course, about 12. I just came back from Miami Beach late this afternoon,
Okay.
and I was we were chopping down some traveler's palms with a chainsaw, and there was two little. I didn't do it, but the guys had forgotten two little corn plant type trees. One was about 2 inches in diameter, and one was an inch in diameter. So I didn't have an axe. I bought an axe, but somebody lifted it, and so the only thing I had to cut with was a spade. So I started chopping away at the small one, and I got it cut with the spade. But then I also had a sharp pain in my left iliac bone. And so I said, uh-oh, I shouldn't be doing this. And so it was only like 10, 11 days out from SBRT. So I stopped. And but that's the only real pain I had. Sometimes, depending on the position I'm in a chair or whatever, it'll start hurting a bit. I just have to switch positions and it stops hurting. So I really can't say, I don't have a chronic pain there. Just once in a while I notice it.
Okay. Anybody have any questions for Joel? Okay.
Glenn, I see you talking, but I don't hear anything.
No.
Hi, Joel. Sorry, I was muted. So you had the SBRT. Were you on, or are you now on, any other therapy?
No, zero therapy, except 8.5 years ago, I had a prostatectomy. That was it.
Okay, so you've never been on hormone therapy?
No, never. No, never been. Either Dr. Anton Arakis is going to cure me without being on hormones, or it's just going to delay, the SBRT is going to delay my getting on hormones. That's the way
What was your Gleason score, Joel?
My Gleason score is 3 + 4, 7, and the highest PSA was 3.8.
Okay.
So we don't like to use the word cure, even though I know some of the doctors do. We like to talk about durable remission, because we're never, we're not quite certain anybody with disease that's come back can actually be cured. That I just wanted to sort of make that little comment when my ears always go up when I hear the word cure. I did want to mention something to you, Joel. We mentioned it just recently, but I don't know if you picked it up. I see that your FMI report showed that you had P10 and TP53.
Correct.
One thing that we've learned recently is that if you have TP53, it can be both positive and negative. And usually, as far as radiation is concerned, I should say, it can be positive and negative as far as radiation is concerned, and usually it's positive. The reason for that is that TP53 makes a cell more receptive to radiation. And And if you have somatic TP53, which is most likely what you have, then that radiation is going to be more effective in killing off the cancer cell. If you have TP53, if it's inherited or germline, meaning you have TP53 in every cell in your body, that mutation, it can be horrendous and cause all kinds of difficulties if you get radiated. So I don't know if you've ever done a germline test. The likelihood is, as Len has pointed out to me, TP53 germline is very rare. But I did just want to mention that, since I have in my notes that you showed TP53.
Yes, I took a germline test. The NBK test did not show TP53. I took Dr. Antonarakis ordered the Foundation Medicine test, if you recall, on me. Checks 326 genes or something.
Yeah.
And that's the somatic test is what found the TP53, along
Okay.
with the P10.
Perfect. So in fact, you are for certain you are somatic TP53, and that's very positive when it comes to radiation.
That's good to know. I didn't know that. Thank you.
I didn't know either. Picked it up from attending a debriefing session on color with a geneticist. So it's just worth knowing. Okay, anyone else have anything that they'd like to talk to Joel about before we move on? Okay.
Rich Jackson has joined us too, Rick.
Yes, was just going to check with Rich. Rich, I see you there. I don't know if you switched your microphone on yet. I just wanted to check in with you and see if you would like, if it's all quiet on the Eastern Front.
Still quiet.
Still quiet on the Eastern Front. Okay. And Larry, and I can only assume it was Larry Fish, looked like he was trying to join us, but he never quite made it. He was in and out several times. I don't know what was going on. He was having some issues. Okay. Let's move on to Dennis McGuire.
Hey everyone. Yeah, so all my test results are back in. I got my genetic testing results from Sloan Kettering. No germline issues. The somatic test results came back with 5 mutations, which Dr. Morris at Sloan Kettering said was pretty standard. I'll just quickly name what those are. There was mTOR, RNF43, TETI, ANK, RD11, MGA. Those somatic mutations, there's nothing actionable or any drugs that are targetable for those mutations. So, got another PA.
Could you just repeat those, please? Because I'm just making a note.
Oh, yep. mTOR, RNF43,
RNF43, RNF43, right?
TETI,
TETI, okay.
ANKRD11.
ANKRD, is that D as in David?
Yes.
RD11, okay.
MGA.
MGA. Okay. keep going, and then we'll come back to this after you've finished your report.
Okay. Yeah, so I had a meeting today with my oncologist at the University of Wisconsin. PSA continues to rise. It's at 14. It was at 11 a month ago. Everything else on the blood test is fine, within acceptable ranges. My last scan, which I had at the beginning of February at Sloan Kettering, showed growth in two areas. The primary in the prostate, there was growth there. And then in the left pelvic lymph node, the iliad. So and that was a PET scan. So the PET scan, the last two PET scans I've had, January and February, are only picking up those two areas of lesions. So those are the test results, and here's where it gets interesting. Sloan Kettering is recommending nothing drastic in terms of treatment. I'm currently on Xtandi, have been for 2 years, and Dr. Morris at Sloan Kettering is recommending giving Zytiga a try and see what sort of run we can have with that. My oncologist at the University of Wisconsin wants to take a more aggressive approach and try, sorry, that's my dog, wants to take a more aggressive approach and try targeted radiation, since it appears the activity and the increase in the PSA is coming from those two localized spots in the primary and that left nodal.
Mm-hmm.
Yeah. So that's my challenge. I got a big decision to make in terms of what to do next.
So I'd like to open this to those of you on the call, and I know there's at least one, and I think there may be more who have had who have metastatic disease and have decided to treat the primary after going through some treatment. So let me pick on Ken, because I know that was his case, and then we'll go to anybody else after that. Ken, what was the thinking with you and your GU medoncs with respect to treating the primary?
Well, hey, Dennis, did you have your primary treated at all? Did you do any radiation to the gland?
No, I had no treatment to the primary. I started with Lupron and docetaxel about 4.5 years ago. That was my first treatment.
Maybe 2 years ago, Dr. Korn and I at MD Anderson discussed, the fact that as cancer progresses, inevitably it starts again to come from the gland, the prostate gland. So we opted back kind of early on, either to take it out, which I didn't really want to do the operation, or radiate it. So I radiated, and I did find in a PET scan recently, maybe 6 months ago, that I had some inflammation that showed up on a PET scan that looked like it was cancer. So I actually went through a biopsy and had it. I was going to radiate again if it in fact was cancer. So the fact that you haven't had the prostate gland radiated, I don't know, I'd probably go ahead and do that. I'd probably talk to your local doc and, your primary doc and say, hey, I'd like to address the primary gland. And I don't think radiating, where's the second node located? Is it in a lymph node?
Yeah, it's in the lymph node in the left iliac, down in the pelvic area.
Did your doctor locally think that he could reach it with radiation, like IMRT or SBR or something?
Yes.
I think that's a reasonable approach. I would probably do that. I mean, it's systemic. We know it's metastasized, so it's not just sitting in those two spots, but
Yeah.
by all means, you might get a good response out of radiating those two spots. So, I mean, radiating the gland is a little bit of effort on your part. I did IMRT, and I know SBRT is a lot quicker. I think they can do it in 5 shots versus, I think I did like 50 trips to the radiation oncologist's office. So I think it was 72 gray, real small doses. I think it's a
Okay.
reasonable approach. I do. I don't know why your primary doctor wants you just to take, stay on, I guess, enzalutamide at the moment and then switch to abiraterone.
Yeah, well, his approach with radiation is only radiate if you're having symptoms, meaning if you have some sort of blockage with urination or kidney issue.
No, I understand.
Yeah.
I do.
Yeah.
And you're not having those issues, are you?
No.
No bone pain, no issues in regards to radiation. But I'd still, if I was you, I would. But I would talk to your doctors about it more and see what their thoughts are.
Yeah, and what the oncologist at Wisconsin is saying, if I showed up for the first time with my presentation of 2 hotspots, including the primary, this is what he would do. He would do radiation.
I think it's reasonable.
Yeah.
And
Okay. Thank you.
Has anybody else in the group today with metastatic disease gone back in and treated the primary with either radiation or surgery? Well, we have a number of people that have done that. Dennis, one person that comes to mind who wasn't on today is Carl Foreman. He was part of an actual clinical trial that removed the prostate with surgery. If it were me personally, I would not do surgery. I would do radiation if I had metastatic disease. Memorial Sloan Kettering actually has done studies showing that treating the primary is very effective. So it surprises me that Morris isn't on board with that. I actually can send you, that was again with surgery, but again, whether you do it with surgery, you do it with radiation is, then we're just debating how we do it, not if we do it. We've seen more recently, probably in this group over the last 2 or 3 years, we've seen at least half a dozen men, if not more, go in and treat the primary, whereas 10 years ago, it just wasn't considered. Mayo would do it. Occasionally, Mayo would often do it. Other than Mayo, Memorial Sloan Kettering occasionally, but few others would actually treat the primary. Len, what are your thoughts on treating the primary?
Yeah, my primary was initially not treated at MSK, and the opinion of the medical oncologist I was seeing at the time was simply, no, we don't use surgery or radiation to treat your primary when you're a Gleason 9 and it's escaped beyond the capsule. I had bilateral seminal vesicle involvement and pelvic lymph node involvement, but at least at the time, no bone metastases. However, so I was on intermittent ADT for about 2 years before Rick and Dominic, guys on this call, persuaded me that I should treat the primary. So I started talking to some radiation oncologists, and I had my prostate and pelvic area radiated. And I think it did me a lot of good. Bought me a few years before I finally did develop bone mets. Now, in your case, Dennis, what I'd like to see you do is talk to both of your oncologists about the CARD trial, C-A-R-D. Rick is familiar with this.
Yeah.
You are kind of a perfect match for the type of study they conducted, whereby they recruited patients who initially had docetaxel, like you did. Then subsequently, they went on to a second-line hormonal agent, in your case, enzalutamide. And then they randomized these guys to either a second anti-androgen, like let's say if they took enzalutamide as you did, then they put you on abiraterone, or vice versa. So that was one arm. The other arm was they gave the guys cabazitaxel. And the guys on cabazitaxel had superior results in just about every measurable parameter. You know, they had longer radiographic progression-free survival, longer time to pain progression. So, you know, you're kind of a perfect match for that trial. So at the very least, you should talk to them about that trial and just get their opinion on why, you know, that isn't the best option for you.
Yeah, well, we did talk about chemotherapy, and even before the scan results came back, we kind of did scenario planning, and they did say that we'll consider chemo if it's advanced beyond the 2 areas. So if you have more widespread disease following the scans, then we would consider chemo. So then the scans came back and it was just in those 2 areas, and they said, oh, they didn't really want to put me through the chemo regimen at this point.
And what type of scan did you have, Dennis? You said PET scan, but was it a PSMA PET or sodium fluoride PET?
It was not a PSMA, it was an Axeman.
Oh, Axeman.
Yeah.
And what was your PSA at the time that you did the Axeman?
The PSA at that point was 11.
Okay.
And today it's 14.
Yeah. Well, look, I definitely think it's worth exploring the CARD trial, but if it were me, I would definitely get my primary radiated together with having them radiate the whole pelvic girdle. I mean, not just that one iliac lymph node, but I'd go through the whole pelvic girdle. And what I would probably try to do is to get this is what I would ask for anyway, would be to have SBRT for the, or some sort of brachy for the gland, and then IMRT for the pelvic girdle. And you know, we've just seen people, and again, it's anecdotal, but we've seen people get good results. And there is a bunch of stuff, I can't recall it offhand, but if you go to Alan Idell's site, which is called, does anybody remember the name of Alan's site off the top? I'm just looking it up here.
Unlocked.
No,
Health.
no. That's the forum that he contributes on, but his own site where he posts his blogs is called Prostate Cancer News, Reviews, and Views. And I'll put well, it won't help Dennis, but I'll put that in the chat window. It is, Dennis, if you have a piece of paper handy, I'll give you the URL.
Sure.
It's HTTPS PCNRV. So that's P as in prostate, C as in cancer, N as in Nelson, R as in Richard, V as in value. PCNRV period, blogspot, BLOGSPOT, blogspot.com. And if you go to there, and if you can search for, treating the primary or something like that. I think he's written a couple of things on that. And as you know from hearing him on here, he's very lucid and detailed, and you'll get a real good feel. But I think there is now some fair old evidence for treating the primary, and I would tend to do that. Now, whether I would just target the lymph node or not in the pelvic region, if it were me, in for a penny, in for a pound, as they say in the old country. I just do the whole pelvic girdle, just like Len did. Len's situation wasn't that dissimilar to yours, except he never had chemo starting off, and he was a little bit older when he got diagnosed. Is that true, Len?
Yeah, but Dennis, didn't you originally get diagnosed with bone mets?
No, only lymph.
Okay.
Pretty distant lymph node involvement. I had a 3-centimeter lesion up in my collarbone area.
But that
doesn't show.
That was a lymph node and not the bone that you had in the clavicle.
Yeah. It was lymph node only, right?
Okay.
Okay, well that's great. That's very helpful. Appreciate it.
Anybody else want to contribute anything to Dennis's thinking? Everybody's so silent today. Like getting blood from a stone here with you guys today. All right.
I have a comment.
Thank you. Thank you, Jake. I feel better. You're making me feel better. Go ahead.
I had no input on the treating the primary, but didn't you also say that they want to follow up the Erlita with the enzalutamide with abiraterone?
Yeah, one of the oncologists recommended that.
Okay.
Switching to Yeah,
well, I hope that works for you, but don't be surprised if it does not, because many people that go from one to the other find very little success. I don't want to be Debbie Downer, but it's just something to be aware of, and don't be too surprised if it does not work very well for you.
Exactly. No, I think that's why the Wisconsin oncologist is saying not a good option, because the cross resistance is so high.
Right. I mean, it does work for some people. There's a small percentage, but it's a very small percentage, unfortunately.
Yeah.
So that was my 2 cents.
Thanks. No, thanks, Jake. I mean,
Thank you.
it's around 8 to 10% from memory. Does that strike a bell with anybody?
Yeah, my recollection is 10 to 15%.
Yeah, that sounds about right.
But even
Okay.
that was only like a 3 to 6 month response. It wasn't a great response.
Okay. Okay. All right. So we'll move along. Keep us posted, Mr. McGuire, please. As I recall, you quite like that fella at Dr. Lang, Joshua Lang at Wisconsin too.
Yeah, he's a good guy. He conferred with Dr. Morris at the ASCO in San Francisco about me, but I guess they didn't come to the same conclusion on what to do.
Well, yeah, as you may have recently read, because I put it into one of my reminders. Oh no, I put it on a blog post. If you guys haven't read Peter Kafka's blog post on using two doctors, I recommend you read it. It's very good. And we put it on the blog earlier this week. And I put in a sort of editorial comment in there based on the experience of somebody who's actually on this call. And one thing that we sort of notice is that when you have two doctors, they tend to sort of dance around each other a little bit. And they don't always come to the same conclusions that they might give you individually. So they'll tell you one thing, you might talk to your two doctors, your lead doctor, your second doctor, and they'll tell you one thing. But when they talk to each other, they sort of don't want to contradict each other. So you may sort of have to jump in and make the decision that you want to make based on that. And we've seen that in more than one occasion. There's no hard and fast rules or responses, but I think it's something that's worth you keeping your antenna up for when you do have more than one doctor. And there's one other thing before, Russ, we have plenty of time and we will definitely come to you. But there is one other thing that I wanted to raise, which I was reminded of by your various mutations. By the way, I did want to check in. Len, did any of those mutations mean anything to you?
I actually never heard of any of them.
Okay.
And you know what they would say is, the VUS, variants of unknown significance, they might be totally meaningless.
Right. But what I do want to do is really, and I put this in the reminder, I really want to encourage everybody who has not signed up to the Metastatic Prostate Cancer Project to please go on their site, watch the little 2-minute video if you like. If you want more information, just Google, or the link is in my reminder, or you can go to our website and you can Google MPCP, and you can find the hour-long presentation that Ellie Van Allen made to us. But this is a terrific project. And it's a patient participation project, meaning that all of the samples and the research are coming directly from patients out there. They're appealing to patients to provide samples. They now have over 900 samples. And the idea is to try and map prostate cancer to see how frequently various mutations show up. to see if people with certain mutations respond better or worse to certain diseases, et cetera, et cetera. And it's a great project. And by the way, it's part of 6 or 7 different projects for different diseases. So there's one for breast cancer, and there's one for some sort of sarcoid tumor. I forget what they are. Count Me In is, I think, the name of the website. But Len, I know you've participated. Would you like to just maybe say a few words about the MPCP project?
Yeah, I agree with you, Rick. It's a great project, primarily because they freely share all of the data, which could help cancer researchers, no matter where they are. I just wish that there would be more follow-up of the same patients. Like, for instance, I first entered their database when it first started. I don't know, it was several years ago, I guess. And, my disease has progressed. I've been on certain treatments. I had a second genomic analysis. It seems to me that they'd really learn a lot more if they, ask the patients for updates on their status. So don't you think that would better enable them to see, okay, well, this guy had these treatments, but his disease still progressed. This guy, his disease was stable. This one became NED. Seems to me that would be a lot more useful. If it's just a one snapshot in a point of time, it seems incomplete.
My understanding is that they do that. They get a release from you, and they get your medical records, and then they do follow up on the medical records on all their patients.
Oh, well, I hope they do that. That would be good. I wasn't. They certainly didn't notify me if they did get follow-up records.
Yeah,
Didn't you sign a
I have
release?
not heard from them at all since
No,
I had
no.
mine.
When you sign up, you sign a release, and that authorizes them to go to MD Anderson and get the information as it progresses,
Yeah.
or wherever you go. I do
Yeah.
remember signing this medical records release.
Yeah.
So I think Rick is correct. They're tracking data. I don't know how frequently, but I think they're pulling data from your primary doctor. I do believe they do that.
You need to look at the release, but Jake, I'm concerned that you haven't heard anything, because you should be on their mailing list and you should be getting quarterly updates.
No, not getting anything.
Are the rest of you guys getting your quarterly updates?
I wouldn't say it's quarterly, but I think it's every 6 months.
Yeah.
Yeah, I agree with Ken.
Yeah, they are. I mean, reach out to them, Jake, and make sure they've got your email, because you should be they are sending out reports.
Okay.
And not only are they sending out reports, they're sending out other information, like how to use the database. I remember I sent that to Len, and they sent out a very good little video on how you can go in and play around with the database. I mean, it's a little technical for us, but not for Len, but for us normal people.
That was difficult for me too.
Oh,
Of course, you're not going to identify your own data. It's just general pooled data.
Yeah, the data is all totally anonymized. I should have said that to you before. The data is totally anonymized, but the presentation is good. And again, please, and Len, what is actually involved? You give a saliva and you give a blood test. Can you tell guys what they have to, what happens?
Yeah, once you sign up, they send you kits for a saliva test for germline genomic analysis, and they give you tubes of blood with instructions to have blood drawn. You go to your local lab, and it comes. So they draw the blood, and they put it in a pre-addressed envelope provided by MPCP, and off it goes. So, and of course, as Ken said, you sign a release of medical records information.
Len and I are actually going to be talking with them next week. They reached out to us to see what feedback we had. Len clearly has some feedback, so we'll tackle that with them, Len. But do look at your release before we raise that one with them. And so, because we'll address it, but we might want to address it, phrase it slightly differently depending on the actual release. So yeah, so this is again, this is an unabashed plug to please sign up for the MPCP, and I'm in the spirit of full disclosure, Eli is on our advisory board. He wasn't when we first started working with them, but since then we've gone to him. And by the way, let me give you one benefit of that. We had one of our guys come back with a variant of unknown significance that is in the BRCA2 family. And so we wrote to Eli this week and said, do you know anything at all about this? Has it registered anywhere or with anybody else? And it had not. But I mean, that's the idea of this project, that we could go to him and say, look, we got a guy with these mutations. Do they seem to mean anything for prostate cancer? So, anybody have any questions? I have put in the chat box. I've put the link to the project on the web. It's MPCP project. MPCproject.org. MPCproject.org is the website, and look at my reminder, and the videos are all linked on there. The 2-3 minute one and the longer presentation. All right. Any questions, anyone? Okay. Russ Smith, we're coming to you. And Russ is saying, wait a minute, because I can see it.
I had it. I had my phone on mute. I had to get to the right button.
Okay, we're with you.
So just a real quick update. Based on seeing my medical oncologist at Dana-Farber, I started on the Casodex yesterday. So today was only my second dose. So I've begun my 6-month journey in ADT and radiation, and so now just trying to get used to the Casodex pills, which hasn't been too bad. It's a little bit of a headache. That's about it. I think that levels off after a week or two. So that's all I got.
Yeah, I mean, I must say, for me, the Casodex bicalutamide didn't bother me at all, but of course everybody's different, as you'll find out. But we're really glad. We should just add, for those of you that remember, when we last spoke to Russ, he wasn't sure if the doc had prescribed the Casodex as a buffer, and we talked about the buffer. But as it turned out, the doc had done it, and Mrs. Russ was on top of it, fortunately. So so that was nothing to worry about. So you know, I don't think not only will you probably notice very little from this, but for the first 2 or 3 weeks after you get the Lupron shot, most guys don't notice a lot from that either. So anybody?
They're going to start with a 1-month dose, and then build up from there.
Okay. Sounds like a plan. Anybody else? Len, anything you want to say to Russ about starting on this journey?
Well, I can't really add anything to what you said, Rick. You know, everybody does respond differently. Hopefully, Russ, you'll be one of the guys who tolerates it very well. I feel like I tolerated ADT very well. Never had any serious problems. Never had uh, night sweats or any of these serious hot flashes. Had very mild hot flashes. Um, you'll feel some fatigue, but I'm sure we must have told you last time around, exercise is the key.
Right. I just got off the treadmill when the
Oh, yeah, that's
call
right.
started, so.
I remember seeing you.
Yeah, we saw you. We saw you on that. We saw you on that treadmill. You know,
Something a little more intensive would be good.
yeah, we want to see you in a striped shirt, though, Russ. That's what we want to see. We want to see you in your zebra uniform.
Well,
So,
baseball's first. If I'm up to doing it, that starts in about a month, and then the real target. I don't really care if I miss baseball this season, but yeah, I want to be in good shape to start football in August, and so that's the plan, that's the goal. I don't know yet when I start the radiation. Generally, it's 8 weeks after you begin the Casodex, I believe. So I'm just trying to schedule out and kind of get an idea of when that radiation may start. I see my radio oncologist on March 11th to determine what the plan is.
okay. Yeah, that sounds about right. It's usually about 4 to 6 weeks after your first loop, after you get your first LHRH dosage. So that sounds about right. Did you get the pamphlet, the UCSF hormone therapy pamphlet that I sent you, and did you get a copy of Richard Wassersood's book?
I did. Thank you.
Okay, so they're both worth studying, because not only will they fill you in, I can't say. I don't know Richard's book as well as I know the UCSF pamphlet, but I know that in the pamphlet we gave a lot of good tips on how to mitigate some of the side effects as they arise. And I think, as I recall, at the end of each chapter, Richard has tips on how to deal with some of the issues as well. So it's both are very practical.
Good. That's all. Thanks, guys.
Well, thank you. Thanks for hanging in. Well, this is fantastic. Look, it's 20 of the hour, wherever you are, and we've been through everybody. Have I missed anybody who wanted to say something today?
I'd actually like to ask if anybody on the call today has ever had an Eligard injection.
Yes.
Okay.
I have this last, I've had several for just about 2 years.
Yeah. Have you also had Lupron injections, Les?
Yes, was off Eligard for several months, or well, actually it was close to 2 years, and then put me on Lupron.
You have any preference for either one?
No, not really.
Did you get little nodules in your? You got the Eligard injection in your gut?
Yep.
Did it leave little nodules, and were they just temporary or long lasting?
Just temporary, and it wasn't much of anything, just a little spot there, and that was about it. That's about all I had.
Okay.
Lynn, it's Rich.
Hi, Rich.
Biggest issue I had with the Eligard was the second shot. I think they went in a little deep, and it felt like somebody hit me with a baseball bat for about 2 months.
Whoa.
That the only answer they could come up with was they hit muscle tissue, abdominal muscle, instead of subcutaneous fat.
Right.
On a toss-up between side effects, I prefer Eligard to Lupron.
Okay. Yeah, thank you for that. I guess I was a little concerned that they went a little too superficial because when she withdrew the needle, there was like a little droplet of the Eligard just on my surface skin. So I thought maybe it was a little too superficial or she pulled the needle out a little too soon. But I guess I'd rather have that than what you apparently had when they go too deep and they hit muscle tissue.
It felt like somebody punched me when I wasn't looking. It was about 2 months or the 3-month shot.
Okay, good to know. Thanks.
Oh, Mr. Jackson, why don't you share your new? It's not totally quiet on the Eastern Front because you have good news because you got into the trial, right? You want to just share that?
It's not finalized yet.
Oh, okay.
I'm penciled in, but it's not finalized yet.
Okay. Okay. All right. So, anyone else have anything? We may actually be able to finish this call early. Or anybody have any questions?
Yeah,
for
I
Len
do.
or I?
I do.
Go ahead.
Okay, I sometimes I still, after all these years, I still get these drugs mixed up. Eligard is the Garalex?
No,
No, it's
Eligard, Jake, Eligard is exactly the same as Lupron. They're both called Leuprolide acetate. There's just different formulations. One is intramuscular, the other is subcutaneous
okay.
injection. Otherwise, they're the same.
And that's why Rich said he got it in his stomach?
Right, as did I.
Oh, okay. That's why I was getting confused. I'm getting that confused with the Firmagon, which I know you get in the stomach.
Yeah, Firmagon also goes into the stomach. Yeah, but it's a deliberate deep subcutaneous injection with Firmagon.
Okay.
Yeah, apparently with Eligard, maybe to avoid what happened to poor Rich, they tend to make it a little more superficial injection.
Okay. I've never had anything other than Lupron, but I've never had an issue with the Lupron. You know, it feels like they hit me with a baseball bat for a couple of days, and then after that it's gone. It does. I don't feel anything. But
yeah,
that was just my comment. Thank you.
Yeah, there are a number of those agonist drugs. There's Zoladex, there's Trelstar, Eligard, Lupron. Probably missing some. I'm probably missing out. Oh, and then there was something I heard yesterday on NPR. The health spot in the morning yesterday about a drug that was available as a generic, but the insurance wouldn't cover it, and the cost was $4,000 as a generic, and I think $30,000 as the label drug, and it was being used for kids that hit puberty very early, but the generic form had been developed for prostate cancer, and it was some sort of a pellet that is placed under the skin that, as I understand it, is some type of LHRH drug, and I meant to look it up and I forgot. Does anybody know about that type of an LHRH that's inserted under the skin?
Well, that sounds a little bit like a depot to me.
Yeah, but it's not. It is a depot, but it's not done as an injection. It's like a pellet that they just put in under the skin.
Huh, I have not heard of that.
No, well, I'm trying to remember what it was called, but I can look it up on go to yesterday's morning edition and find the name of the drug on there. But I hadn't heard of it either. So whatever it is, they're not selling much of it as an LHRH alternative, and I don't know anybody that's used it.
What I find interesting is, as you said, that they won't cover the generic form of it, but the insurance won't cover the generic, but they will cover the full name brand. That's a little bit weird.
Well, the reason is because the generic is really, it is a generic in that it's exactly the same drug in a marginally different dose, but the generic has not been approved for this condition that this kid had. Okay. And only the online drug has been approved for that. So it's kind of an off-label generic. It's exactly the same drug, but the pharmaceutical company doesn't want to sell it for that use because they can sell the more expensive drug.
Well, that's understandable, yeah. But that's for children to prevent children from reaching puberty too soon. What about for the cancer?
Well, the prostate cancer is available. If you were taking it for prostate cancer, you'd be taking this generic form.
Okay. Okay. As you know, it's not hard to confuse me, but you did.
I'm very good at that, though, Jake.
I'm pretty easy to confuse.
I have a PhD in confuser, Jake. Sorry, I'm so sorry about that too. I'm not proud of that.
Rick, I just did a quick lookup. It's called Suprelin, at least I guess that's the brand name, and it is a GnRH or LHRH agonist, but it doesn't say which one. Supprelin.
How did you find it so quickly, Professor?
I just put in precocious puberty and prostate cancer drug, and it came up.
Well, right, Suprelin. So I've never heard of anybody using it.
I never heard of it.
Is it available in the United States? It must be, because this was the point. That was the point of the webcast of the on MPI yesterday.
Yep.
And it is approved for prostate cancer.
Well, I'm trying to find what the actual drug is. Huh, it's amazing they don't. It's hidden somewhere. They just keep, even in the package insert, they just refer to it as Suprelin, not the generic.
Here it is. It's histrelin acetate.
Oh.
Histrelin. Histrelin acetate.
Okay. Never heard of that.
And it's a subcutaneous implant.
For prostate cancer.
Yeah.
Well, maybe I should ask my doctor about that. If you know, since I'm having issues with the LHRH, obviously, do you think that might be a feasible alternative for me?
Could certainly ask her.
Yeah, I doubt if she's even heard of it. But
what I will say is that it talks here about Suprelin as that it talks here about it being the early puberty treatment. I wonder if it has a different name for prostate cancer. Well, you can try. You have enough information. What is it called for prostate cancer, or, you know, one of you guys can. Vantas.
Lantas?
Vantas.
Oh, Vantas.
That was the name, yeah. Vantas is a brand name prescription medication used for the palliative treatment of advanced prostate cancer. It works to lower the levels of male sex hormones such as testosterone to help slow the growth of prostate cancer cells. Vantas comes as an implant that's inserted directly under the skin.
Huh.
So,
does it say for how long it lasts? Or is it a 1 month, 3 months? Does it say about that?
I've got not on what I'm looking. You'd have to, but why don't you, if you Google Vantas, you'll find it. So Suprelin is what it's called if used for precocious puberty, and Vantas is what it's called if used for prostate cancer. Vantas.
Okay. Cool. Thank you. I'll look that up after this meeting.
Okay. All right, guys. Well, we've managed to burn off all but 7 minutes. And who knows, maybe we've come up with another more friendly LHRH that some of you might want to try and might want to use. Now, I'm just looking to see if it says anything here about, it talks about the dosage, it just doesn't talk about the frequency. And it is approved, but I don't see the frequency, so you'll have to do, I'm sure it's in here, but a 150 milligram implant, hey guys, you're gonna love this if it works. The usual recommended dose of Vantas for advanced prostate cancer is 150 milligram implant inserted under the skin every 12 months.
Oh my goodness, that's almost too good to be true. My doctor won't like that. He says, I'm not gonna make any money out of that.
That's maybe why we don't know much about it.
Very well, might very well be.
And I'm reading this off of Medical News Today. Here, I'll put it in the chat window. So now, the other thing is I can see why it's used for advanced, because a lot of people may not need to be, a lot of people may not need to be on for 12 months continuous.
Right. Well, I would certainly qualify for the advanced and
Yeah. So there you go. So let's well, if anybody else wants to check it out, talk to their doc about it. That's interesting news, that Vantas. Well, I hope everybody stayed on until the end of the call, because they would have found something useful out of the end of the call.
we did lose a few.
I know, it serves them right.
That's
Okay.
right.
Okay. All right. Next call is Monday, first Monday of the month next week. I don't think we have anything else for you guys. In fact, the last meeting of the month is coming up in about 45 minutes for multiple sclerosis. And as I may have mentioned, it looks almost certain we're going to be starting publicly calls for blood cancers and also for ovarian cancer in April, if you know anybody, and we should have sign-ups for that on the website within a short period of time. All right, I'll say good night to everybody and talk to you next week.
All right. Thanks, everybody.
Good night.
Good night, everyone.
Bye-bye.